I wanted a diagnosis, but some clients don't. I felt it was very helpful to me to go through all the 9 criteria, realised that I fulfilled all of them, and then I worked on them, and I found that that was the most integrating process for me. Not everyone wants to know their diagnosis, and that's fine. I think new therapists need to learn how to handle their own anxiety when talking to people with BPD. Essentially, if they can hold their own anxiety in check, then it's not going to be contagious to the person with BPD. I think validation skills, active listening skills, the ability to sit in those uncomfortable feelings, whether they're coming from the client or the therapist, need to be addressed and looked at. I think that a new therapist needs to have his or her own therapy so that they can handle their own anxiety, know their own trigger points, and so that countertransference doesn't happen too often in therapy. Stigma is a huge problem, especially when people go to emergency departments, mainly because clinicians and mental health nurses, psychiatrists, psychologists sometimes are not up to date with new information and new research, which essentially says that people with BPD can get better and do get better with the right treatment. And it's also when people come to emergency departments to ask the right questions, not why did you do this, but what happened to you? What happened to you before you did this? So the right questions need to be asked, as well as there needs to be hope for recovery, because people do recover from BPD. I think education is the way to go. Increasing up-to-date information for people, having people with BPD, the peers with lived experience, to go into ED and have a talk to people, to say when I come in dysregulated, my behaviour is not who I am. There are times when I function perfectly well at home, but when I'm dysregulated, this is the only place I can come to. You are the only people who can help me at this moment before better or newer services come into it. So what I want you to do is to be able to listen to someone's story and understand where they're coming from. People do not want to come into ED and be thought of as manipulative or attention-seeking, because if we want to live a life, this is not how we want to live it, coming to emergency departments.